All right. Well, welcome again to another episode of Probing the Literature. This month, we're going to be talking about ultrasound and trauma. And we have an awesome special guest lined up for us. Not awful. I was trying to say things at once. So we have awesome special guest who's going to be talking about her paper. But I also want to just go ahead and mention that thank you for everyone for joining. If you can put your cameras on. The way that this session works is that we have the first half is going to be with our invited author who's going to describe their paper. And this is a great time for you to kind of get some background information about what goes on in behind the scenes of different research projects. Our second half will then be breaking into small groups, and we're going to discuss another article, and we really want you guys to be involved. And then for the final few minutes, we'll come back together to kind of talk about some salient points about that discussion. And then finally, if you want to stay around for the second half or the second hour, that's when we're going to be doing methods consult. So bring any interesting research questions you may have for us then. Okay, so let's move on to discussing our first article. And our first article is going to be by Dr. Kat Ogle. She is an associate professor of emergency medicine at George Washington University, and she's engaged in medical education and professional development from undergraduate all the way to the faculty level. She does direct the GW UFAC accredited ultrasound fellowship, and she leads the medical education and leadership scholarly concentration, as well as the clinical as a medical educator course. She's had served in leadership positions in local, regional, and national organizations, including the GW Committee on Equity, Inclusive Excellence, and Inclusive Excellence. She is currently the president of the Academy of Women in Academic Emergency Medicine through SAEM, and she was previously on the board for the Society of Clinical Ultrasound Fellowships. She's an award-winning educator, and her professional interests include medical education, point-of-care ultrasound, mentorship, diversity, equity and inclusion, and leadership and promotion. So not only is she an amazing academician, but she also has a great mom as well. So I'm excited to have Kat talk about her paper here. Going to be discussing about the FAST exam. So Kat, do you want to go ahead and take it away?
Absolutely. Thank you so much for the invitation. Our team was very excited for our article to be featured. And I want to give a shout out to our senior author on the paper, Sarah Frasure, who's one of our APDs and one of our core ultrasound faculty. And she is simply a rock star. And she's done a phenomenal job of generating some very cool research ideas. And so I want to start with, how did this idea come to fruition? And I'm not sure how y'all do it in your shops, but at GW, we will have probably a quarterly research happy hour. And I think that happy hours are really where the best ideas are generated. And those are often done after we've had a journal club of our own. So we're sort of thinking research minded. We're sort of coming up with interesting ideas. And for this particular happy hour, we were trying to understand why we had residents who were having false positives and false negatives. Because, being a little bit prideful, we feel like we're doing a really good job of teaching. So how could they miss that? Or how could they not see that? Or why did they call that positive when it was not positive? So that led, of course, to a quick dive into the literature to figure out where those false positives and false negatives are mostly coming from. And then, we got to thinking about the resources that we had in our environment. And, most of us are using some sort of a cloud-based system by which to archive our images. And we thought, well, we have all of these images. And in our shop, our trauma activations are queued with a trauma name. So they're fairly easy to filter. And so we're like, what if we went through all of these trauma activations and figured out which ones were false positives and which ones were false negatives, and try to identify some patterns there. And that's really where the idea came from. Any questions so far?
No, I think that's awesome, because I think so much of this is, where does this clinical question come from whenever you're thinking about this. And so trying to use that to help you to answer a question that you face in your own, educational program is actually, I think, where a lot of these questions come from. So no, that's great.
So for a little bit of context also about the research environment in our shop, we actually have dedicated research associates who staff our ED, pretty much from 7 in the morning until 11 at night. And so for our clinical research projects, they're there to sort of help identify patients. Now, we set this up as, a retrospective observational study, so we didn't necessarily need our in-house research students to get involved. But because we have them in our network, we were able to recruit one to help us with looking at this data set. And so, as I said, we wanted to look at a dedicated group of trauma activations, and ultimately we were able to identify in the study period 4,860 total eFAST exams that were performed. I'm not sure how the undocumented, technically limited, or incomplete studies are looking in your shops, but we had a 29% undocumented rate. And we knew that we had a problem. Once we started looking at the numbers, we were like, oh, we really have a problem. And so, there are other things that we're looking at on the back end that are not necessarily relevant to this study that we're trying to do to ameliorate that and to positively impact that. But when it came down to it, we were able to identify out of that entire group of studies, really only 27 false positives and 75 false negatives. Then things got a little bit tricky. So we have QPath as our database where we do the interpretations and billing and whatnot, but then there's the actual patient chart. And in our shop, there's still a paper flow chart for the trauma activations. And documentation of the FAST exam occurs on that piece of paper as well. And then that piece of paper gets scanned into the chart. So you have to go through the chart, each individual chart, and find that scanned document, which is usually called trauma, to find that information. And then you have to scroll through the 6 pages of that huge trauma flow sheet to find the FAST exam documentation. So for our false positives and false negatives, we actually found once we went to the trauma flow sheet, there was a discordance between what was documented in the trauma, like the trauma bay, versus what was documented in QPath. And, there's probably a number of reasons why this happens. And, we kind of talked a little bit about it in the paper, but, part of it, I think, is documentation fatigue. And, our residents want to just quickly go through and check some boxes, and perhaps don't actually look at our QA system the same way we do as faculty. So we open those images and we're nerding out. We're looking at every single image, and we're trying to make sure that we're seeing the relevant anatomy, and we're asking ourselves, do we see everything we need to see? But I think when residents who are managing multiple other documentation and clinical responsibilities go in there, they try to do it quickly. And, there are probably some things that we can do on the faculty side to adjust the approach here, but it is what it is. Unfortunately, what that did is that actually decreased the number of false positives and false negative exams that we had to analyze. So the ones that were finally analyzed, we looked at those images independently of the interpretation, just to see that our interpretation matched the interpretation. There were a couple of situations in which our interpretation didn't match the documented interpretation of the resident, which is what you would expect when you have a false positive and false negative. But when there's a disparity, we actually had a second reviewer come and take a look at the images independently of that data as well. On the good side, we found that we're pretty darn good at pulling together negative FAST exams. So your true negatives and your true positives, we're pretty good at that. And when we looked at reasons for exams being false positives, they were small things like, a resident misinterpreting the pericardial fat pad, for example, as, a pericardial effusion, or looking at the perinephric fat that is adjacent to, the kidney and the spleen, or the kidney and the liver, and then thinking that that hypoechoic area of adipose was actually free fluid. And, the other piece that we had actually hypothesized in the beginning was that we expected a lot of our false positives were going to be patients that had physiologic free fluid in their pelvis. Because how are you going to differentiate between physiologic free fluid in the pelvis versus traumatic free fluid in the pelvis? There were a couple of those cases, but that was not the vast majority of them. And there were a couple that I think we were not anticipating, and that was residents who identified the seminal vesicles actually as free fluid in the pelvis. And so what that information does for us from a teaching perspective is that allows us to go back to our residents and really talk about some of the pitfalls of doing the FAST exam and the things that we have to be mindful of, and how you really do differentiate between the things like the double line sign and a pericardial fat pad and seminal vesicles when you're teaching them. And so you really talk about the fact that, your free fluid in the belly should be fully anechoic. It should tuck into corners, adjacent to, structures. It shouldn't be uniform in size. It shouldn't be symmetrical, because you're really kind of tucking in all the nooks and crannies inside the peritoneum. But I think what the study really kind of highlighted for us and kind of gave us pause in is, what do we need to do about documentation, and what are we missing in this analysis because of our ability or our inability to incorporate those 1,400 exams that had to be thrown out. We might have had some changes in our numbers for our false positives and our false negatives if we had been able to incorporate those exams. So that's kind of a summary of the study itself and some of the things that we thought about, but I'm happy to answer any questions that y'all have.
I'll out myself as the dum-dum. What's the double line sign?
So the double line sign, I think we cited an article that had pulled together a representation of the fascia that's around the kidney, adjacent to the liver and adjacent to the spleen, where there is this perinephric fat that is sort of outlined by that hyperechoic fascia. And so you literally have two parallel lines running right along the structure where you would expect like your hepatorenal or your splenorenal recess to be. However, it's hypoechoic, not anechoic, and it's uniform as opposed to sort of tucking in and being triangular.
I think that's interesting. It's fascinating that your study wasn't billed as like a medical education study, but that's really what this is, and how you're taking what it is. You're able to, I think what's great for our fellows and junior researchers to know is that you can take a problem that you have and you can publish that, but then that also gives you a lot of feedback on how you can adjust your teaching, how you can change things as far as departmental processes. All of these things, kind of came out of what you're describing. From what you're saying. And I think that that's something that's a really big deal, because then that kind of opens up other categories for you to potentially have academic work. And so I think that that's, really interesting how, because we have a very similar problem in our trauma center, is that we have the paper sheet. They put a little Type-Inex band on it. Every patient gets a little red band, and then it's always a matter of scanning. And it's interesting how you have a discrepancy sometimes of like, you say, call out fast negative, but then later on, when people have time to actually look at those images more clearly, then sometimes you get that where you're like, oh crap, that's actually positive. And then what do you do? How do you meet that discrepancy? Like, how do you adjust for that? I think is really kind of an interesting point. And so I think that's something that this is really kind of helps, I think, a lot of us who are having that same problem kind of address. Do you have any questions from the rest of our group?
I had a question about your pneumothorax misses. If you noticed any trends in terms of like technique, or I mean, it's hard when you're reviewing images to know like what part of the chest were they scanning, because at least in our shop, nobody labels very well. In fact, we're lucky if we get a right and left sidedness, honestly, and that's a big problem we're dealing with because we're looking at kind of launching a similar type study. So I thought this study was very heartening to read, just to kind of see that, hey, you know, lacking in documentation percentages are kind of like a problem across the board. It's not like unique to just, you know, I've been failing at my job is like getting my residents to do it. It's just kind of hard across the board. So I really appreciated getting to see that published and see others kind of wrestling with the answers to those questions. But did you notice any trends in your pneumothorax misses?
Yeah, so I think we have to be very careful about, and it kind of comes back to teaching. If we simultaneously reviewed the trauma film from that video, we would see that some of these residents had the probe up by the clavicle.
Yeah.
When they're doing a supine assessment for a pneumothorax. And really, when you're doing a supine assessment for pneumothorax, your probe needs to be at the highest level of the chest. And so that's problem number one, which we can't tell just by looking at ultrasound images, unless you can literally see the clavicle there. But what we saw more often in the images in reviewing them is the probe was moving while they were doing the lung ultrasound. And that's one of the things that I tell my residents over and over again is, you know, the lung ultrasound is not a dynamic scan. Your hand should be very boring. And what you're trying to assess is you're trying to assess what the lung is doing. How is the lung behaving? If you're moving your hand around, you really cannot definitively say that you have lung sliding.
Yeah, we've seen examples, and just doing a lot of QA in the last few days, trying to get our database ready to kind of look at a little more formally of residents literally getting bored, you know, with one clip, a 4 to 6 second clip, staying on one side and literally hopping over to the other side and catching both in the same clip, which really confounds your sort of, you know, looking at this and saying, well, which side did they start on the right always or not? You know, yeah. So that is a problem we've seen too. It's interesting.
Yeah, we always do the discussion. I always tell the residents, if the object is moving, you need to be still. I think that is something that you often see, especially with learners, is they are trying to get in a clip so quickly. Like our residents are taught to kind of slide down. Well, I'm like, but you have to pause at each interspace. You sliding down the chest, is that moving? I can't tell what's happening. So that's kind of like the rule of thumb we always say. If the object's moving, you hold still. If the object is still, then you can fan through it and move.
And Dan, to your question about non-educational systems changes, what I will say that we have incorporated since that time is when we are reviewing QPath and we filter for trauma cases and they're not submitted within a week of the actual case, we will do a chart review and we'll look for the trauma flow sheet. And we will queue it out as undocumented, but we'll bill for it because we can say that it was, you know, negative or positive in the trauma bay and correlate that with any of our comprehensive studies. It's a little challenging to do because at least in our system, we use Cerner. And after the patients are prepared for discharge, they go back to their normal name. And so you can no longer search for them by their trauma name. And so if the resident didn't put the medical record number in, then we actually have to filter sort for the time of arrival and look for like chief complaint and figure out who the attending was on. It's like literally takes probably 20 to 30 minutes per case to do this deep dive. And, you know, on the one hand, is that annoying and is that frustrating? And for those of you who, you know, are in your fellowships now and you're sort of stepping into this administrative role, yes, that's challenging. And if you are looking at this from a patient safety standpoint, you need to be looking at those images and make sure that those things are documented accordingly. And so that would be the systems change that we made.
Have you ever thought about starting like a POCUS CSI sort of like branch fellowship?
You're really tugging at my heartstrings right there. I love this idea.
I think we
Who was on the machine last?
do the chocolate chip things to get the residents to do it the right way, because there's really no way to get them to consistently do it. They'll do it for a week and then they'll forget, just like taking pictures of blood vessels for lines, or, you know, the iWorks protocol that Dr. Mersch mentioned too. That was great. It worked for a couple weeks and then they kind of forgot and were like, we're not going to do it. Doesn't help us out.
Got it. So Jeff, not all of our trauma activations are hemodynamically stable. We have 2 levels of traumas at GW. So one is a trauma white, which is a lower acuity trauma. And it's really, loss of consciousness mechanism. Your higher level traumas, our trauma yellows, are the ones that would be considered potentially hemodynamically unstable. But we didn't explicitly parse out that data. I think for some of the false negatives, we did find that a couple of those cases were high velocity mechanisms or penetrating injuries that had solid organ injuries like liver lax and splenic lax. And again, when the faculty re-reviewed the images in QA, we could clearly see that there was fluid. It just was missed by the residents. And I think some of those cases were also partially clotted blood, which for a novice sonographer, which I would consider a 2nd-year resident or a 3rd-year resident, they're still a novice. And so their capacity to be able to see, partially coagulated blood and confirm that, like, oh, this is a fluid line, as opposed to, oh, that looks like bowel. I think that's a nuance that you just get with experience.
Yeah, I think that's definitely, it's interesting. It would be interesting to see. I don't know if you guys thought about that, like breaking it down by class, like as far as, who is more likely to have the false negatives or false positives. That would be, I don't know if that would help as far as if you're trying to hit a specific target group. But for us, we've kind of done that. We found that like we now have a QA system, like a QA little course we do for FAST exam to try and get our residents to not miss so many things. So we have the same thing with the coagulated blood, is always throws them off. So that's just an interesting thing to think about.
Yeah, and I mean, I think it's also important to acknowledge that anything that increases your cognitive load, like an unstable, traumatic, injured patient in front of you, has the potential to impact your decision-making and your assessment in that moment, particularly if you're less experienced.
And I think see Jen Cornell put in the in the comments talking about that exact same thing. Sometimes just in the moment you've got too many things going on, and stepping back, like you get a lot more information from that if you don't have all those things weighing on your mind at that exact moment you're making the decision. Great point. Yeah.
Jen, you're in my brain.
And it's
in your brain. I'm happy there.
Is there a name for that concept? Because I've actually looked, because I kind of believe that too, that kind of stepping away and reviewing images and not actively acquiring them, I think it increases accuracy, but I couldn't find any research or studies on it, or even does it have a name, to learn about? So, because I want to convey that to my learners too, but I don't even know where to start the conversation sometimes. So just wondering if anyone knows.
It's a great question. That sounds like a great research question. Potentially a great research idea.
Got a couple of people giving you some ideas in the chat for what you can call it. But I think that's so true. Do you guys have, like, I guess the question is, like, so when you guys were doing this, was it just the resident who called out like the exam, what the diagnosis was, positive or negative, or do you guys also have an attending who kind of looks over their shoulder?
Yeah, so for our trauma activations, there's either an EM attending in the room, or there's a surgery attending in the room. So they are looking over the shoulder of the resident as they're doing the exam.
Any difference is in the discrepancy between the 2 different types of attendings? It's always a question.
We have some of our surgical colleagues are actually quite facile at ultrasound, and our inter-rater reliability is actually quite high. And I mean, just as you would expect in lots of places, there's some disparities as well. Mostly,
I don't know that
get the fast done faster is where the disparity comes in.
But like, I still don't think surgical programs have like formalized numbers of like scans that must be performed for their residents. And so it's super heterogeneous. Yeah.
Yeah, they're simply required to look at those really incredibly well done ultrasound videos from ATLS, and that's the ultrasound exposure that they get.
There are recommendations regarding SICU fellowship in terms of numbers and things like that. But again, those are recommendations and not like program requirements. So.
Yeah, I think that's, so much that is like, variable. So it kind of depends, I think, where you are and whatnot. But I agree with you that the more, it's very heterogeneous as to who it is, which I find interesting that like, the next article we're going to be talking about, same thing, where there's not enough numbers to really to compare the two, which is an interesting point.
And Dan, to your question about whether or not we've created a lecture specifically to address this, we have, we've done a false positive, false negative series, but it's not just FAST exams. It's actually all comers, but it may be worth us, I see your face, like the duodenum diagnosed as cholecystitis. The surgeon didn't like that.
I love that idea of just like the false positive, false negative educational series. Like, that's brilliant. Wow. I never thought of that.
It's pretty fun. And I think that it gets a lot of aha moments for folks. Yeah, it's really interesting.
And I think being willing to show like images that are just not pristine too, that aren't like what we would typically consider lecture quality, right? Like, or textbook quality, because that's the reality of like people being asked to make decisions on imperfect information in stressful situations. So like they have to see that sometimes these clips are not going to be idealizable and you just have to make the call,
Yeah, absolutely. Absolutely. Well, that was just a great discussion, guys. Thanks so much, Kat, for coming and talking about your paper. We really, really appreciate it. If there's any other questions, we'll get to that maybe after our next session, our next grouping, which is we're gonna be breaking into small groups to talk about our second paper. And so our second paper is kind of a Cochrane review, so kind of a global review of the difference between ultrasound for pneumothorax and trauma versus chest x-ray. So I think Dan is going to get us to break up into small groups, and what we'll do is we'll all discuss